Okay, our next speaker is Dr. Jesus Rodrigues-Bano from Spain. Dr. Rodrigues-Bano is the immediate past president of the European Society of Clinical Microbiology and Infectious Disease and the associate editor of Clinical Microbiology and Infection. He is also the scientific chair of the Spanish Network for Research in Infectious Disease. Dr. Rodrigues-Bano will present on Spain from the front lines. Dr. Bano.
Thank you very much, Kevin, and thank you all the organizers for inviting me to this very interesting webinar. I'm really enjoying all the presentations. As Kevin said, I've been serving the European Society Clinical Microbiology and Infectious Diseases for a while, and we also organize several webinars. We discuss what is the experience in different countries, and I think this is a very important activity because we have to learn from each other. We have to know where we did well or worse than others and try to learn from the mistakes that we did, but also from the things that others did better or worse. So my presentation will be mainly my personal point of view about what has happened in Spain. I will provide some information and some data that were publicly available from our Ministry of Health and our authorities, but I will also try to provide some personal views on how we lived the epidemic in the country and how things were moving on during this time. So Spain is a country located in the southwest part of Europe. We have half of our coast to the Atlantic Ocean and half of the coast to the Mediterranean Sea. A country, we have 48 million population. Our country is composed by 17 autonomous communities. Spain is not officially a federal country, but it works very similar to a federal country. So these autonomous communities have the competencies for a lot of things, including healthcare and public health. Public health system is a public health system that covers all the population. It's a universal coverage. So everyone has the right to be attended from primary care to very specialized care throughout the country. This healthcare system has been thought to be very good for years, but it was really stressed during the pandemic. And I think that we found out that there were several things that need to be fixed in this situation. Another interesting, important aspect to consider is the way people tend to behave. We are a Mediterranean country in the way we live and behave regarding our diet or our behavior. So we like to touch each other, we shake hands frequently, we hug each other and kiss each other. So we have a very close contact, and this is very typical from Mediterranean countries, and this is also relevant in this kind of outbreaks, I think. Well, you can see here in the slide how has been the curve of the epidemic. This is the new daily cases. So far, we are near 300,000 cases in the country. As you can see, and I will be providing some details, we peaked around the last week of March, starting from the very beginning of March, of our number of cases. The way the country was affected was also very heterogeneous, as Christine said for the Netherlands. It was also the case in Spain. So if we just try to see what are the daily number of deaths, you can see that we peaked a little bit later than the number of cases as expected. The peak was in the very early of April. Total number of deaths is around 29,000. If we estimate the number of excess death rate in the country, considering the expected death rate for this period of the year, the estimation of the excess death rate would be around 40,000 for all these 3 months. We are sure that part of this excess of death will not be directly related to COVID, but indirectly probably related. So here you can see the daily number of deaths. Some of the days we were between 700 and 1,000 number of deaths per day in our country. If you just consider the cumulative cases and death, you can see how the curves started to plateau by end of March, both of them, and you will see in a minute what is the explanation for that. So you can see that there was a exponential increase in the cumulative number of cases from the last week of February until I would say the third, fourth week in March, and then both for number of cases and deaths, and then we reach the plateau. If we compare what happened in Spain to what happens in other European countries, and I didn't include Netherlands because Christine was speaking and was going to explain with detail what happened in her country, I can show you here what happened in Italy, UK, and Sweden. I chose these three countries because I think there are some important aspects to consider when we compare this what happened to Spain. Italy was probably the first country in Europe to raise an important number of ICU admitted patients due to COVID-19. In fact, we in Spain learned that we might have a serious problem when our Italian colleagues warned us about that. And as you can see in the graphs in Italy and Spain are pretty similar. In both countries, there was a very rapid increase in the number of cases over 2-3 weeks. And then after the measures were undertaken, there is a steady decline in the daily number of cases. So both of the countries were severely affected, were probably the first, together with the Netherlands actually, countries to be affected in Europe. And both of the countries were able to control the situation in a, I would say, similar way. In the UK, you can see that the curve is a little bit different. The reason for that is probably the fact that the UK authorities started with a different policy. They considered that they could, even when there was evident transmission within the country and a good number of admitted patients, they considered that they could control that situation by track and tracing and not closing the country. And it was when they realized that it was not possible anymore when they started to a different message like closing down the country. But the close was never as effective according to indirect data as it was in Italy or Spain. As I will explain you later, the lockdown in Spain was very, very effective. And in the bottom right graph, you can see the situation in Sweden, where they also considered that they could allow transmission to occur with the theory that would cause a herd immunity in the population if a substantial number of people get infected, and that would allow, let's say, a more normal life or a less restrictive measures. But at the very end, they also had to recognize that was not the appropriate policy and they have to change it at the very end. As I explained to you, the impact of the pandemic in Spain was very heterogeneous across the different regions. I will show you a map in a minute. The most severely affected regions were the central regions around Madrid, around the capital, and also around Barcelona, the two bigger cities in Spain. And these were clearly the two more heavily affected areas. And in these two areas, the capacity of the hospitals and the intensive care units were clearly surpassed. You can see here that this is a picture of a campaign hospital that was built in Madrid, in the Feria of Madrid, in the convention center for attending 2,000. It was a capacity for attending 2,000 patients, and patients with lower severity was transferred to this campaign hospital. So that was necessary because of the overload of patients in 2-3 weeks of time to all hospitals in Madrid area. Other cities also have very stressed situation for the healthcare system with limited available beds for intensive care particularly. But in most of the country, the situation was at the limit, but was able to be managed appropriately, I would say. I show you again the graph of the outbreak in the country just to try to explain how it evolves according to the measures that were undertaken. So I think that when we started to see cases in the last days of February, first week in March, you can see that there was like in 9 of March, we have one day with almost 1,000 new cases. At that time, those cases were mostly, or 95% of those patients were hospitalized patients. These were not patients with mild symptoms, but were patients who were admitted to hospital because our capacity to diagnose patients was mostly centered in admitted patients. So the last days of February, we learned from our Italian colleagues that they had ICU cases. We all thought that we should have also cases around. What we know about the infection is that if you have one very severe case, you have several dozens of milder cases around. So probably the virus had been circulating throughout the country, maybe sometime during January, but for sure during February, and it exploded by the end of February and beginning of March. So when we realized that we have cases, we really had a big problem already in the country, which was perfectly unnoticed. The reason for that is that, as Christine explained before, we could only test patients with respiratory symptoms if they were coming from China, from Wuhan region, but not in other situations. It was only after the first cases without clear travel relation with other cases that we could started to test patients, and therefore it was when we just knew that there was community transmission. So clearly we had not undertaken measures before, and that was one of the reasons that when we realized that we have a problem, we already have a huge problem in the country. So as you can see in the first vertical line, it's on the left, it's when the government set up the alert state, meaning that the government could take control of all decisions. As I told you before, the regional governments in charge of the public health and health care in all the regions. But from that point, it was the central government who had to take control of all the measures. And the decision was that day to lock down the whole country. The lockdown was complete. I will explain that in a minute. We were expecting to see some results after 2 weeks. Typically, after 2 rounds or 3 rounds of transmission could be stopped. And it was actually what happened. You can see that by end of March, the number of cases reached the maximum. And from there, it started to decline steadily. Second line, starting from the left, is when the first de-escalation phase was undertaken. You can see 2 different colors in the bars during that period. It's because the darker orange is cases diagnosed by PCR, and the slighter orange is cases diagnosed by serological tests. And you can see that the de-escalation was not done in all the country, but only in regions with a specific rate of transmission, was started from there and was continued until the last line in your right, which is when the country was, I would say, fully open again, as I will explain you in a minute. So this is how the epidemic evolved in the country, and this is how the measures were undertaken. So, of course, report of confirmed or suspected cases is mandatory in a daily basis in a hospital. The information is centralized by the central government. It's reported by the autonomous community in the same days. It's communicated to the central government. The statistics typically only include confirmed cases by PCR and during a period of time by serology as well. You have to take into account that during the first weeks of the epidemic, only admitted patients were tested. After the opening of the country again, or the de-escalation of the phases, we started with the track and trace policy, and then most of the recent cases are asymptomatic contacts of other cases. So therefore, it's very difficult to compare the situation between what is happening now and what happened at the beginning of the outbreak. And deaths are declared when there are confirmed cases by PCR, but we add the estimations done based on excess mortality. I will come back one slide just to show you that during, I would say, the worst parts of the epidemic, we only tested patients admitted to the hospital, while most of the cases in the right part of the graph are either patients with mild symptoms or asymptomatic contact of new cases. And I think that's important to understand what is the situation in each point. In our country, seroprevalence study has been performed. Actually, this study has been done thrice. There are 3 rounds of serological testing throughout the country. Representative sample of the country population was chosen. It includes around 60,000 people, of which more than 50,000 got tested. And this is the publication with the first round of serological tests. So this is the seroprevalence in our country. As you can see, the situation of the seroprevalence indicated a higher rate of transmission that had occurred in the central part of the country around Madrid. In Madrid, we have 11.3% of seroprevalence, and the surrounding areas in which many people live but work in Madrid or travel to Madrid frequently, you can see that there are similar prevalence data. In Barcelona, in the northeast part of the country, we have 7% of prevalence. And as you can see, in other parts of the country, the prevalence was much lower, indicating a very heterogeneous transmission of the virus throughout the country. This seroprevalence test has been repeated in 2 other occasions, and the results are pretty similar to this. Some important data came out from this regarding the exposure to some risk factors, and etc. And so if you are interested, you can consult the publication because I think that it provides some interesting information. So what were the specific public health measures that were undertaken? So as I explained, March 15, there was a national alert and a countrywide full lockdown that lasted 8 weeks. So during this period of time, everybody had to stay at home for everything. So you could not get out of home except for people working in indispensable jobs or for short walks with your pets or for going to the supermarket if needed. But everything was closed apart from that. And our indirect data coming from consumption of energy or some other indirect data suggested that the adherence to the lockdown was very, very high. And it was one of the highest in the countries that measured that. So it was specifically done, but it was also very highly followed. After that, the escalation period was started. Not all the countries started at the same time. It depended on the regional rates of transmission. So the first phase for the escalation included the possibility to perform in sports outdoors, to have walks with children, to open some specific establishment with previous appointment, and wearing surgical mask in whatever the situation in which you could not be, maintaining the social distance that was set up at 2 meters. Phase 2, Phase 3, and Phase 4 included different, let's say, opening measurements, and increasing the number of people who could meet in specific circumstances, but always keeping the distance, opening of restaurants, of shops, but with limited capacity, and a capacity according to the possibility of keeping the distance. In Phase 3, we could move within the province, and in Phase 4, we could move freely across the country, and everybody should go back to work, maintaining the social distance and mask, except in situations in which it was not possible. So the situation now was named like New Normality, so now is the way we are. But in terms of following the disease, what we are doing is that every patient, every person with respiratory symptoms is recommended to call the primary care center to have an appointment and be tested by PCR for coronavirus. And of course, every single positive patient is traced for the contacts, and all the contacts are also tested and preemptive isolated until the results are available. Since the full opening, some 72 outbreaks have been detected and are being followed. This was the figure a few days ago. Maybe now we are around 80. Many of them are active, meaning that still contacts are being traced or are being followed. And 2 districts in the country, one in Catalonia and the other in Galicia and Aragon, has been set up back to the partial lockdown recently because there was not evidence of control of transmission with the track and trace policy. So in these two districts, people went back to phase 2 of the previous measures, and with the possibility of even go further if needed. Most of these outbreaks are related, 50% of these outbreaks are related to family or friend meetings in different situations, and much less frequently are related to other circumstances. So clearly the highest risk is posed by these meetings in which people do not have the feeling that they are at risk because my relatives or my friends or whatever are asymptomatic or still are asymptomatic, or I don't have the impression that this is a risk, and this is where people might get the infection. Also, I would like to point out that use of surgical masks is being compulsory now in many of the regions in the country. It was compulsory for all situations in which you could not keep the distance, but now many of the regions are making them compulsory for everyone and everywhere. What happened in hospitals? Well, during the first 2 weeks, particularly in hospitals in the most affected regions, there was also kind of chaos, as Christine explained. It was also the same experience. There was a huge number of patients coming to these hospitals every day, a huge number of new positives. Many of the hospitals have to convert other areas to ICU beds, etc. You can imagine that caused a very important chaos. There was also a shortage of protective equipment. So during these 2 or 3 weeks, the situation was really tense and really stressful for all healthcare workers. And the situation, I would say, that normalized by end of March related to PPE's availability. All hospitals included differentiated circuits from the triage of patients in the emergency department for any patient with suspected or confirmed COVID-19. All of these patients underwent PCR with a really rapid turnover time in most hospitals. And in non-COVID circuits, PCR was indicated when the patient needed any elective aerosol generating procedures, but not otherwise. Some hospitals, like my hospital, also included universal screening for admitted patients, unrelated whether it was COVID-19 suspected or not. And we detected a few asymptomatic, from respiratory point of view, positive patients, and we are investigating the relevance for this. The situation now is that there is universal masking in hospital for both healthcare workers and patients or visitors. So everybody has to wear a surgical mask. Of course, patients admitted in their beds when they're alone, they had not to wear it. But if the doctor is going to attend them and they tolerate it, they should wear a surgical mask as well. When we attend patients in the COVID-19 circuit, we use respirators, eye protection, gowns and gloves. For non-COVID-19 patients, we use precautions according to procedures, and in nursing homes, we use universal screening with PCR whenever there is any case. The situation in nursing home is very similar to what Christine described. There was a good number of cases and deaths related to nursing homes. Healthcare workers have been tested from mid-March when developing symptoms or were contact of other healthcare workers or positive unadmitted patients, and some hospitals also perform universal testing of healthcare workers on several occasions. Important in the seroprevalence study is that the proportion of healthcare workers that has antibodies against the COVID-19 SARS-CoV-2 were 10%, which is double the general population. So probably healthcare workers were more frequently infected than the general population. It may have to do with the problem created with lack of PPEs during the first weeks, also with the chaos generated in hospital during the first weeks, and probably that's the explanation for that. It is a huge discussion within the country about this. As Christine said, there is some evidence suggesting that when PPEs are appropriately used, the possibility of transmission or acquiring the infection from healthcare workers is very low. But still, this is the reason why in our country, respirators are being used whenever managing any patient with suspicion or confirmed COVID-19. So in summary, I would say that there are some things that we could have done better. For example, delaying massive testing. We could not test our patients without epidemiological contact with China until there was also already a good number of cases. I think that there were several factors for that. One was a lack of, let's say, availability of the PCR in all hospitals. Also, the fact that the situation seemed to be controlled in China, etc. Probably there was a delay in the close down of the country, in the lockdown of the country. This has been heavily discussed also and became a political issue as well. The protocols for infection control and for avoiding transmission in the community has not always been as clear as I would like them to be. And the change in protocols were not always clear, even for healthcare professionals. And I think that in some of the decisions, there were not enough input from people working in hospital, from clinical specialists, clinical nurses, who could provide very good information for what was happening in the front lines. I think that there were things that were well done. First, the close down of the country and the high gatherings to the lockdown of the country. I think that was an important thing. The phases for the escalation probably were well designed and also followed. The information from the seroprevalence study has been very important for some decisions. The healthcare was reorganized throughout the country and it was done in a very short period of time and very efficiently. I do think that the clinical work with patients was good in general terms. There was a fantastic collaboration from many clinical specialties. The work of the nurses has been outstanding, and the implications of all healthcare workers has been really fantastic. We were allowed to increase our human and laboratory capacity resources, and that was done very, very soon. And that, of course, helped us to try to work during the epidemic in a better situation. So more or less, this is a summary of what I wanted to explain. I would like to thank everybody working in the front lines in our country, nurses, doctors, persons working in all the services from cleaning to administrative. Now we are very much worried about the potential of rebounds after the opening of all the measures. But I think that the work being done now in primary care is being very good, and we do hope that if there will be rebound, that I'm afraid there will be, we would be able to cope them and avoid a chaos like we live in early March. Thank you very much.